All right, so we're gonna start with the eosinophilic lung disease. And the definitions for this: pulmonary opacities with peripheral eosinophilia. So if there's an abnormality on the chest radiograph, but the patient has peripheral eosinophilia, then you can suggest diseases in this category of eosinophilic lung disease. Lung tissue eosinophilia confirmed by biopsy, increased eosinophils on bronchoalveolar lavage fluid. Sometimes that occurs even if the peripheral eosinophil count is not elevated. So those are the definitions for eosinophilic lung disease. The eosinophil itself, there are more eosinophils within the tissues than within the blood. And these are granulocytes that develop in the bone marrow. They're carried by the blood to parts of the body exposed to the external environment. So the respiratory, GI, GU, mucosa. And these eosinophils contain granules. The granules stain pink with eosin. That's why they're called eosinophils. And these granules contain enzymes that damage parasitic worms and modulate mast cell-dependent hypersensitivity reactions. So things related to the external environment. That's what eosinophils are about. So if we start with this case, I tell you this patient has cough and fever. The eosinophil count is elevated. The finding on the chest radiograph shows what?
Right upper lobe consolidation.
Right, so there's a right upper lobe consolidation here on the chest radiograph, plus minus small pleural effusion. And then we see a few days later what changes on the chest radiograph.
So resolved. The right upper consolidation is resolved, but now there's like consolidation at the left lung face.
Okay, so we don't see this anymore, but we do see additional consolidation here, right? What about the left side? See anything on the left side?
At the base.
Yeah, there's something here, also here. The location of these opacities are what? Peripheral. Now, what do we call it when we start out with a consolidation and then it's in different locations? We call this what? I can't hear you.
Migratory?
Migratory, right. So you have these migratory consolidations. Given the history that I've given you, this is the classic appearance for what?
Loeffler syndrome?
Yeah, so Loeffler syndrome, also called simple pulmonary eosinophilia, right. And on CT, you may see that the consolidations are distributed peripherally. So this is simple pulmonary eosinophilia, also called Loeffler syndrome. So these patients have blood eosinophilia. They might have mild symptoms, cough, fever, shortness of breath. The symptoms are present for less than a month. Okay, they can have transitory, migratory, spontaneously clearing consolidations. If there's pathology, they'll find eosinophils and histiocytes within the alveolar air spaces. And it's usually self-limiting. It usually takes care of itself. Although it's thought that in Loeffler's original description, most of these patients probably had ascariasis, but still it can be idiopathic, and again, usually resolves on its own. So if we have those peripheral migratory consolidations and we have peripheral eosinophilia, this is one of the eosinophilic lung diseases that you might suggest. On this chest radiograph, we give the history of cough for 6 weeks. The patient has a history of asthma. Eosinophil count is elevated. The finding on the chest radiograph is? Yes, so peripheral consolidations, right? And so if we have peripheral consolidations, but given this history, right, the history of asthma, what do we think about now? So here we consider chronic eosinophilic pneumonia. These patients usually have longer onset of symptoms, cough for 6 weeks, so symptoms are usually present for more than a month. And again on CT, it can have these characteristic peripheral consolidations. So this is chronic eosinophilic pneumonia, insidious onset, symptoms usually present more than a month. It can progress. It's strongly associated with asthma. They can also have upper respiratory problems. The thing is, it is treatable with steroids. You might be the first one to suggest the diagnosis. So that's very important. So if you notice those peripheral consolidations, happen to check the blood work, you see there's eosinophilia, also if the patient has asthma, then we're in this, think about this disease, chronic eosinophilic pneumonia. And it responds very nicely to steroids. These are the findings that are associated with chronic eosinophilic pneumonia. Features of this, this is the most striking of the eosinophilic lung diseases, to have this peripheral distribution of consolidations. So it's been described as the photographic negative of pulmonary edema because of the propensity of the consolidations to be peripheral. This is a case we had here, 29-year-old man, history of asthma, progressive shortness of breath for greater than a month. He was a carpet remover who did not wear a mask. So the chest radiograph shows these consolidations. He had peripheral eosinophilia, had bronchoalveolar lavage, which was actually full of eosinophils. The important thing is when you look at the chest radiograph, it's not obvious that the consolidations are peripheral, but on CT it can be, right? So CT, the distribution of the consolidations is obviously much more easier to determine than on the chest radiograph. Okay, so if on the CT we notice peripheral consolidations like this, then we can't think about the eosinophilic pneumonias. And then this patient was treated with steroids, and you can see the rapid improvement, both symptomatically and also radiographically, after the patient received the proper treatment. So you might be the one. Hello? Yeah. Can we mute, please? So. Okay, excellent. Still would help if you muted. So if we have peripheral consolidations, if you notice them on the CT, then you can bring up this possibility. What parasite can do this and is associated with the eosinophilia? What do these parasites have in common? There are various parasites that can do this, but what do they have in common? Worms with a migratory phase through the lung. This was ascariasis. All right, that's what these parasites have in common. So these larvae of these worms, the nematodes, they have a migratory phase through the lung, and when they're migrating through the lung is when the patients can develop symptoms, consolidations on the chest radiograph, and they might have peripheral eosinophilia. So they can have transient non-segmental migratory consolidations, very similar to Loeffler's, and as we said in his original series, most of those patients probably had ascariasis. And so the disgusting life cycle, I will leave it to you to study, but basically when the person ingests the eggs, the larvae penetrate the small bowel, and then they get into blood, and they migrate to the lungs, and then all the bad stuff happens, okay? Biopsy showed necrotizing vasculitis and tissue infiltration with the eosinophils. Surprise, we have peripheral consolidations. But here, given this history, especially the history with the vasculitis, there is a particular disease that we need to mention. What is that? What do we call it? I can't hear you. Churg-Strauss, right? Or eosinophilic granulomatosis with polyangiitis. So this is a vasculitis. So it is associated with elevated ankle levels. That's usually how they would work up for any kind of vasculitis. So these patients can go through various phases. So they can have asthma, eosinophilia, and then they can develop the vasculitis, especially involving extrapulmonary organs. So I've given you the diagnostic criteria. These are 99% specific if anybody fulfills 4 out of the 6 criteria to make this diagnosis of Churg-Strauss syndrome. And it is a necrotizing vasculitis. The tissues are infiltrated with eosinophils, so-called these eosinophilic abscesses, so these packed eosinophils that form these granulomas within the tissues. So it may result from a hypersensitive reaction to some unknown antigen, but it is a vasculitis, and it can evolve through various stages. There's an asthmatic phase, an eosinophilic phase where patients have blood and tissue eosinophilia, and then a vasculitic phase that can affect many organs with this. So they can have upper airway or lung involvement. They can have these non-segmental consolidations that can be transient and patchy. They can also have cardiac involvement with this. Peripheral parenchymal opacities, there's a variety of appearances, central lobular nodules, bronchial wall thickening, but kind of nondescript opacities. They might have a peripheral distribution, as you see here. They can be consolidations or ground glass or nodular with this. Another disease that is we don't think of as an eosinophilic lung disease is asthma. And the eosinophil is the most characteristic inflammatory cell that's associated with asthma. So, and it infiltrates around the small airways. So asthma can be described as chronic eosinophilic bronchitis. So these eosinophils then will form around the airways here. And they're also found in the bronchoalveolar lavage fluid. These patients also develop smooth muscle hypertrophy, which are the straight arrows here, that smooth muscle hypertrophy, which causes the constriction of the airways, and then the parabronchial eosinophils, which are the curved arrows here. So what do we see on chest radiograph? Well, in uncomplicated cases, especially in children, there will be hyperinflation, parabronchial thickening because of that inflammation around the airways. And that's best seen on the lateral view. So on the lateral view, you look for the airways and you'll notice that they're thicker. They're kind of, the rings are a little bit thicker than normal. So that's parabronchial thickening, best seen on the lateral view in these patients with asthma. Air trapping, so these patients will have increased lung volumes here on the CT. You can see the parabronchial thickening there in this particular patient. The air trapping, of course, is best seen on the expiratory views. So if you're looking for air trapping, you do expiratory views, although sometimes you can see the mosaic attenuation or mosaic perfusion even on your inspiratory views in these patients. You can see these areas of air trapping here on the expiratory views. So here's your expiratory view. You can see the air trapping much better. If I didn't tell you this was expiration, how could you tell that's an expiratory view? Yeah, so the posterior border here, the membranous portion of the trachea. So the cartilage doesn't move, but the posterior border, that membranous portion in expiration, that tends to move anteriorly. Okay, so that's often how you can tell, even on a CT when it's not supposed to be an expiratory CT. If you happen to notice that that's displaced anteriorly, then you've done an expiratory CT scan. Okay, so another feature, and we get this a lot from the ER, they don't necessarily tell you the patient has asthma. The patient shows up short of breath, and of course, what study do they get? They get a PE scan, right? And so you might be the one to notice that when you go through here, you look at the airways in the lower lobes. Notice they look much smaller than normal, and that's because of the parabronchial thickening, because of the narrowing of the airways. So you'll notice that the airways are much smaller than normal, and they have parabronchial thickening. Another thing that's often seen is mucus plugging of small airways. So that's called the peekaboo sign, where as you go through, as you scroll through the image, you see the airway, then it disappears, then it comes back. And that's mucus plugging of small airways. So as you look through the CT, if you happen to notice that, think about asthma, and then you go through the chart, and then you see that, okay, the patient has asthma, and they never told you, in the history the patient has asthma. But that's something that you can pick up on the imaging also, that suggests that the patient has reactive airway disease or asthma. So this patient has asthma, has this chest radiograph. What's abnormal? Okay, so the left diaphragm is elevated, right? What else is abnormal? So if you have elevation of the diaphragm, right, that suggests that there might be what? Okay, that suggests there might be volume loss, all right? So are there other signs of volume loss in this patient?
The left hilum kind of elevated.
Yeah, so the left hilum looks elevated. So elevation of the hilum is always a good sign of volume loss on either side. And which lobe would you expect the volume loss to be in? Yeah, so if the hilum is elevated, that suggests that there's volume loss in the upper lobe. So you're thinking about volume loss here in the left upper lobe. Is there another clue that the patient has volume loss in the left upper lobe? Yeah, there is a Lufsickle sign. What about the mediastinal contours, though? Yeah, the left heart border is not well seen, right? So why would that be? Because it involves the lingula, and the lingula is part of the left upper lobe. You brought up the Luf-Sickle sign. What is the Luf-Sickle sign?
It's like an interface between the left upper lobe bronchus and the arch of the aorta.
So it's this lucent crescent of air that you can see adjacent to the arch of the aorta. It's a plain film finding that's associated with left upper lobe collapse. But what causes the Luf-Sickle sign?
So like the superior segment of the lower lobe.
Yeah, so it's compensatory. When you have left upper lobe collapse, you get compensatory hyperinflation of the superior segment of the left lower lobe. That comes upwards and it can become border forming with the aortic knob. And so that gives you that crescent of lucency adjacent to the aortic knob. What view would confirm that you have left upper lobe collapse? Lateral views, on the frontal view, it's often confusing, but the lateral view can confirm it. And what's the finding on the lateral view that helps?
The retrosternal clear space is the last one.
Yeah, so there's increased opacity in the retrosternal clear space, right? What else? What actually confirms that this is left upper lobe collapse?
The major fissure is displaced.
Yeah, you can actually see the displacement of the major fissure. This demarcation here, see it? That's the major fissure on the left side that is displaced anteriorly. So all of this opacity anterior to that is the collapsed left upper lobe, right? So this is a patient with left upper lobe collapse. We've said the patient has asthma, so what's going to be the cause then? Mucus plugging, right. So these patients develop mucus plugging, and it's common for them to develop atelectasis. So after they cough up the mucus plug, everything goes back to normal. That's the patient looking normal again. You can see the left heart border, Luf-Sickle sign is gone, hilum is no longer elevated, right? So this is the appearance of left upper lobe atelectasis. Another patient with asthma, what do we have here?
Finger and glove sign.
What?
The finger and glove sign.
So what is that? The finger and glove sign is a plain film finding, right?
Right.
Right? But, so what are you describing then? You're thinking about what? What does this represent?
This is the mucus plugging.
Mucoid impaction, right. So this is going to be mucoid impaction. What are the clues that this branching opacity is mucoid impaction or is related to the airways as opposed to being vascular because it is a non-contrast CT? What's the clue on the CT? I need to be thinking about airway disease here. You have these what? Yeah, so you have these nodules, and the distribution of the nodules is predominantly, you said tree and bud, but central lobular, right? So you have central lobular nodules, some of which are tree and budding. So all of that is suggesting that this is an airway disease. And so when you have a branching opacity like that in somebody with these other findings, then we're going to think of mucoid impaction, okay? So an asthmatic who has mucoid impaction, by the way, what do you think the size of the bronchus would be here? Is that normal size? No. So what do we call that? It's abnormally dilated, right? I mean, this is, if you estimate what the size of the bronchus is going to be, it's going to be pretty big, right? There's bronchiectasis. So you have an asthmatic with mucus plugging like this with dilatation of airways, what do we think about? Well, it's not in an asthmatic, right? We said the patient has asthma. Plus, do you see disease on the other side? No. So we don't like cystic fibrosis. ABPA, allergic bronchopulmonary aspergillosis, right. So allergic bronchopulmonary aspergillosis, this is associated with asthma. These patients develop mucus plugging, damage to the airways causes bronchiectasis, can get recurrent infections, peripheral atelectasis, the plain film finding, of course, is the finger and glove sign. So bronchiectasis in an asthmatic can be a sign of allergic bronchopulmonary aspergillosis in these patients, okay. Now, there is a feature of bronchiectasis from mucoid impaction and allergic bronchopulmonary aspergillosis that might be characteristic for ABPA? What is the feature of the mucoid impaction that can be characteristic of ABPA?
Hyperattenuating.
Yeah, the increased attenuation, right. So the high attenuation. Now you can get that also with isolated areas of mucoid impaction. If they've been there chronically, they might also develop high attenuation. But in ABPA, this is a feature, is the high attenuation mucoid impaction. Why is it high attenuation? Why is it high attenuation? Mucoid impaction. Usually we identify mucoid impaction because it's fluid attenuation, right? Why in this case is it high attenuation?
Is it like dissipated or something?
That's what?
Like the secretions are
I
like
can't hear you.
dried out. Like
No,
no.
no.
Proteins.
By the way, the same thing when you for those of you doing neuro, when you're looking for ABP, not ABPA, but when you have sinusitis, right, from aspergillosis, right? What's the finding on MR that suggests it's aspergillosis? Artifacts. Receptibility artifacts. Why?
It's mineralized.
Iron and manganese. So iron and manganese is associated with the aspergillosis infection itself. And so that can cause the high attenuation on CT and also the MRI findings and susceptibility artifact findings that you see on MRI. Okay? 28-year-old severe shortness of breath after 1 week of binge smoking. And you can see the widespread consolidations, and you see on the pretty bad disease there on the CT. Of course, if we see something like this, you'd ask questions about vaping also, right? Because that can give you this kind of acute lung injury picture. But when we're talking about eosinophilic lung disease, this is a characteristic history for a particular one of those disorders. Which one? Binge smoking, eosinophilic lung disease that can result in widespread consolidations. And it's not unusual for patients to go into respiratory failure. So which one of these syndromes are we talking about? Yeah, so this is acute eosinophilic pneumonia. And the peripheral eosinophil count might not necessarily help you in this case as opposed to others, because acutely it can be normal in these cases, and the peripheral eosinophilia may develop later, right? So that's something to be aware of. This also responds dramatically to steroids, which is why it's important to make the diagnosis. You can see what happens after steroid treatment in this patient. So this is acute eosinophilic pneumonia. So it can be a severe illness. The lung is infiltrated by eosinophils. Can be a hypersensitive reaction to some inhaled antigen, but we can also see it now associated with change in smoking habits or binge smoking. And it's the eosinophils that have been recruited to the lung, releasing their enzymes, that cause the damage in the lung, and so those widespread consolidations. Vascular permeability is the mechanism there. So peripheral blood eosinophilia, usually not present initially, but may occur during the course of the disease. As opposed to chronic eosinophilic pneumonia, this is not associated with asthma. So it is associated with smoking, binge smoking especially. There's diagnostic criteria, not very satisfying, absence of parasitic, fungal, or other infection, no relapse after discontinuing of steroids, prompt and complete response to steroids, so it's kind of too late before you made the diagnosis, right? But there it is. The radiologic findings probably result from pulmonary edema, so you can have ground glass, consolidation, septal thickening, pleural effusion. So sometimes the picture can look very much like pulmonary edema, interlobular septal thickening, ground glass opacities here throughout the lung. So that we might see with acute eosinophilic pneumonia. As opposed to the other forms of acute eosinophilic pneumonia, this one does not have a characteristically peripheral distribution. Okay, so this one is different from the others in that this one will not have a characteristically peripheral distribution of alveolar opacities. Eosinophil count is humongous, 2,000 chronically. Okay, the finding on the CT is
Peripheral consolidations.
these aren't peripheral consolidations. These are what?
Nodule.
These are nodules, right? So these are nodules, and if we look very carefully, what might we notice here in the periphery? Maybe a little bit of ground glass, right? Why am I showing the cardiac MR? What's the finding on the cardiac MR? Or what are the findings on the cardiac MR?
Filling defect.
There's a filling defect where? Left atrium.
Ventricle.
Yeah, so there's a filling defect in the left ventricle. What do you think it is? By the way, what sequence is this for? Yeah, so this is a dual inversion recovery black blood sequence, right? And this one is, what sequence is that? Hmm?
SSFP.
No, that's not. Can't hear you. That's not a T1. Well, it is kind of, but something was done here, right? This is, what's the bright stuff? Yeah. So this is a post-contrast. This is an MDE, right? Late gadolinium enhancement MDE. And it's important because what does it tell you about this mass? It's not enhancing. So what's the mass? Thrombus, right. What is enhancing? Yeah, the subendocardium is enhancing. There's a term for this, right? What's the term for this? When you have this kind of disease in the heart, given the topic of this lecture, what is this called? Loeffler's endocarditis, right? So Loeffler's endocarditis are the cardiac findings secondary to eosinophilia. And what happens with eosinophilia is that it can damage the endocardium. So the eosinophils can damage the endocardium, and so you can have subendocardial fibrosis, which is what gives you the subendocardial enhancement that you can see in these patients. And because of that endocardial damage, they can develop mural thrombi. So mural thrombi is part of what we see with cardiac damage in these patients who have eosinophilia. This particular disease, with the marked elevation of the eosinophil count, yeah, so it's very rare, idiopathic hypereosinophilic syndrome. So also called eosinophilic leukemia because of the very high eosinophil counts. Okay, so it's those high eosinophil counts that result in organ damage in these patients. So there are no parasites or any other causes of eosinophilia. Mortality usually from cardiac involvement, endocardial fibrosis, which can lead to restrictive cardiomyopathy, neurothrombi, valvular damage. They can also develop thromboembolic disease, usually arterial, resulting in all kinds of other problems in these patients. So all of these organs can be infiltrated with eosinophils. The radiologic findings are usually secondary to heart disease, although transient consolidations from eosinophilic pneumonia is somewhat less common in these patients. Although the nodules can occur, and these nodules with ground glass halos, that's supposed to be the finding that can be seen with idiopathic hypereosinophilic syndrome with involvement of the lung. Okay? And we discussed this already, right? So anybody with hypereosinophilia, if they develop heart disease, that is called Loeffler's endocarditis. We've gone through the pathophysiology, and so you can see that these areas are not enhancing. This patient has mural thrombi in both ventricles here, and there's subendocardial enhancement also in both ventricles from the subendocardial fibrosis because of the eosinophilia. So that's our discussion of eosinophilic lung diseases. So if you have peripheral consolidations and eosinophilia, here is your differential diagnosis. Drug reactions, patients can develop eosinophilia from that also, and might develop consolidations in the lung from drug reactions. So that's your differential there. However, if we have peripheral consolidations, and all you know is peripheral consolidations, well, of course, eosinophilic pneumonia is in your differential for peripheral consolidations. COVID, of course, is in your differential for peripheral consolidations. But what else can give you peripheral consolidations? This patient has fever, cough, no eosinophilia, Patient got better with steroids. Which of the interstitial lung diseases gives you peripheral consolidations like that?
Organizing pneumonia.
Yeah, so this is organizing pneumonia, and if it's idiopathic, it's called cryptogenic organizing pneumonia, right? So that is the idiopathic interstitial lung disease that's characterized by peripheral consolidations. Although organizing pneumonia from any cause, connective tissue disease, any kind of lung damage, can also give you peripheral consolidation. So it's always something to consider if you have peripheral consolidations, organizing pneumonia. Right? So if it's idiopathic, it's called cryptogenic organizing pneumonia. This patient does not have eosinophilia. There's some respiratory symptoms. The patient smokes. And the characteristic feature of these opacities, they are peripheral, and also they are ground glass, right? So peripheral ground glass opacities in a patient who smokes, and they might also have these areas of lucency mixed in with that, because the patient is a smoker. What is this? Yeah, so this is DIP, another of the idiopathic interstitial pneumonias. This one is associated with smoking, and the opacities are actually caused by alveolar macrophages that infiltrate the air spaces. Okay, so that's DIP, discomining interstitial pneumonitis. These tend to be ground glass peripheral opacities. This patient is acutely short of breath. You're reading this chest radiograph from the ED. What are you going to say? What did you say? So what's the sign? What do you call the sign? You have an enlargement, there's enlargement of the hilum here, but you also have a peripheral opacity, right? So each one has a sign, right? The enlarged hilum associated with PE is called the, what is that called? That's called the Fleischner sign. The peripheral opacity from PE, what is that called? Hampton's hump. So the peripheral opacity is from what? Can't hear you. Yeah, that's an infarction. So that's pulmonary infarction. All right. So it's a patient with PE who has pulmonary infarction. Okay. So of course, pulmonary infarcts can also give you peripheral opacities. Right? Sometimes you might have opacities in the upper lobe that tend to be peripheral. Chronic airspace disease in the upper lobes. What do we think about? Can't hear you. Tuberculosis, right? What else? Sarcoid, of course. Yes, sarcoid can give you airspace opacities with a predilection to occur in the upper lobe. So that turns out to be sarcoid. So is your differential diagnosis for peripheral opacities besides eosinophilic pneumonia. So let's move on. This patient presents to the emergency room with hemoptysis and anemia. The finding on the CT scan is?
Diffuse alveolar hemorrhage.
Well, that's not the finding on the CT. The finding on the CT is?
Ground glass.
Yes, so you have ground glass opacities on the CT. Given this history, you are going to be thinking about diffuse alveolar hemorrhage, right? So blood, something else that can give you airspace disease, right? So we're in the category of blood, pulmonary hemorrhage, as causing airspace disease. So with diffuse alveolar hemorrhage, has a characteristic triad of hemoptysis, anemia, alveolar consolidation. So non-specific airspace opacities. It is possible to have this with a normal chest radiograph. So you can imagine how the chest radiograph here would probably look normal in this patient. And it's only on the CT where you see these opacities. So given the history of hemoptysis, if the patient has anemia, you might be the first one to suggest that this is a case of pulmonary hemorrhage. So if I tell you this patient has hemoptysis and kidney failure, these opacities on the chest radiograph, what are we thinking about? What are diseases that can do this, that can give you this combination of pulmonary hemorrhage, hemoptysis, and renal failure? Vasculitis, what else? Good pastures, right? So you're in this category of pulmonary renal syndrome. So this is pulmonary hemorrhage associated with glomerulonephritis. So these can be ANCA-associated vasculitis, Goodpasture syndrome, also collagen vascular disease. All of these can cause renal damage, and can be a cause of diffuse alveolar hemorrhage. So starting with good pastures, this is from antiglomerular basement, the antibody to the glomerular basement membrane, and that cross-reacts with the lung. That's what causes then the alveolar hemorrhage within the lung. With good pasture syndrome, 20% have glomerulonephritis only, and that's called good pasture's disease. Autoimmune disease, pulmonary hemorrhage, glomerulonephritis, the antibodies found in the serum, lung, or the kidney. So that cross-reacts with the lung basement membrane, that causes the pulmonary hemorrhage, usually males. Hemoptysis, anemia, pulmonary hemorrhage. And so the hemorrhage can clear fairly rapidly within a few days. The consolidations can get better. Characteristically, the apices, costophrenic angles can be spared. Immunofluorescence can help to make the diagnosis for the abnormal antibodies. So that is good pasture syndrome, a cause of pulmonary hemorrhage. This patient has hemoptysis, bilateral consolidations, as you can see on the CT. But I also tell you that the P-ANCA is elevated in this patient. What do we think about here? What particular disease? Can't hear you.
GPA workers.
No, the other one. Right? That's microscopic polyangiitis. Okay, this one is associated with elevated P-ANCA. So this is also a vasculitis. So the point is, you can suggest vasculitis. It's not your responsibility to figure out exactly which one. They will work up the patient for the vasculitis. But vasculitis is a cause of diffuse pulmonary hemorrhage. And if you recognize the CT findings of pulmonary hemorrhage, then you can suggest vasculitis in your differential as causing the abnormalities on the CT scan. And then they will need to go and work up the patient for the particular vasculitis. This patient has cough, hemoptysis, anemia, elevated C-ANCA, consolidations in the lung from pulmonary hemorrhage. The additional finding is, so if you happen to look through the folder and you find this, what is that? What's wrong with this? What is it? Sinusitis, right? It's all that stuff in the sinuses, okay? So a patient with sinusitis who has pulmonary hemorrhage, elevated C-ANCA, here the answer is Wegener's, right, or GPA, okay? So these are the ANCA-associated vasculitis. So microscopic polyangiitis tends to have elevated P-ANCA. Wegener's tends to have elevated C-ANCA. Church-Strauss also can be a cause of pulmonary hemorrhage, and not as commonly as these others. All right, so GPA, we've kind of covered this already. Limited Wegener's occurs in 10% of patients with Wegener's where only the lung is involved without the other organs. These patients can have involvement of the upper respiratory tract also, so sinusitis can be associated with GPA. All right. So elevated ANCA, sinusitis, upper respiratory problems, cough, abnormalities in the lungs. If it's from pulmonary hemorrhage, you'll have consolidations. They can also have cavitary lesions, nodular masses. Remember, this was in our differential for multiple cavitary lesions within the lungs. Okay, so these patients can have cavitary lesions also as a result of their vasculitis. It can also affect the airways, so they can have thickening of the trachea, these patients with Wegener's. So if they have ground glass opacities in the lungs associated with hemoptysis, then it's a sign of pulmonary hemorrhage in these patients. Immune complex diseases and collagen vascular diseases, SLE, this can also be associated with pulmonary hemorrhage. So diffuse ground glass for pulmonary hemorrhage, and then there are these other diseases also that can be associated with pulmonary hemorrhage too. If you have a young person with diffuse pulmonary hemorrhage, what's the disease in young patients with pulmonary hemorrhage? What do we suggest there? So this would be idiopathic pulmonary hemosiderosis. So no renal or immunological abnormalities, usually children. It's the most common cause of diffuse pulmonary hemorrhage in children, is idiopathic pulmonary hemosiderosis. They'll have hemoptysis and anemia. consolidations on the chest radiograph, repeated episodes of hemorrhage can result in interstitial opacities also that can occur on the chest radiograph. Okay, so that's idiopathic pulmonary hemocirrhosis in children. So I've given you a list of all the things that can cause pulmonary hemorrhage. You can also see it with trauma, severe infections, ARDS. That can also cause, acute lung injury can result in pulmonary hemorrhage. Immunocompromised patients, leukemia, infections, Kaposi's, complication of bone marrow transplant, that can also be a cause of pulmonary hemorrhage. So we've discussed good pastures, we've discussed vasculitis, we've talked about immune complex disease, these other causes, more miscellaneous causes of pulmonary hemorrhage. And interestingly, in this study of patients with pulmonary hemorrhage, they found about half were from immune causes, half were from non-immune causes. The vasculitis, rheumatoid arthritis also listed here, SLE as connective tissue disease. Interestingly, mitral stenosis, heart disease, can also result in pulmonary hemorrhage. So the elevated pressures within the pulmonary venous system can result in pulmonary hemorrhage in those patients. And drugs, they also have listed there as a cause of pulmonary hemorrhage. Right? So these are other things to consider in patients with diffuse pulmonary hemorrhage. But don't forget about vasculitis and mentioning that in your differential diagnosis. Moving on to cells. What primary neoplasm can be associated with airspace disease like we see here?
Invasive mucinous carcinoma.
Yeah, so the mucinous form of bronchogenic cancer can give you airspace disease. It can be multifocal, and it might present as chronic consolidation. So that's why we include that in our differential of chronic consolidation. It used to be called bronchoalveolar carcinoma, invasive mucinous adenocarcinoma. So if you have a patient who has these consolidations that have been chronic and they can't figure out what's wrong, it's not infection, you can't suggest neoplasm, invasive mucinous adenocarcinoma. This patient happens to have an inflammatory disorder that gives you airspace opacity. As you can see, the air bronchograms in here, right? So what inflammatory disorder might we suggest for this patient and why? Why would you suggest that one?
Sarcoid.
Why would you suggest sarcoid?
It's like the galaxy sign.
There's a galaxy sign, right? So you have these kind of peripheral nodules around the opacity, a little bit here too. That's called the galaxy sign. What other finding here suggests sarcoid? Not just subpleural, but the distribution of the nodules, right? So what do we call that distribution? There's subpleural, right? What do we call this distribution? Perilymphatic, right? There's a perilymphatic distribution of nodules here with these alveolar opacities. So this is a patient with alveolar sarcoid, right? In addition to the consolidation, what else is abnormal on his chest radiograph? What do you think that's from? Lymphadenopathy, right? So if this is all lymphadenopathy and you have airspace disease here, how do you put that together? What do you think it might be? Of course, anybody with cancer can be susceptible to infections and stuff like that, especially if they're being treated, opportunistic infections. But if this is neoplastic, what neoplasm would you be thinking about? Let's take a look. Extensive lymphadenopathy, airspace disease. Well, what neoplasm are you thinking about here? Lymphoma, yeah, this patient with lymphoma. So lymphoma can also give you infiltrative airspace disease, can give you air bronchograms, as in this case, as it infiltrates around the lungs. Okay, so with Hodgkin's lymphoma, it tends to infiltrate from the lymph nodes into the surrounding lungs. With non-Hodgkin's lymphoma, it can be primary disease predominantly within the lungs. So lymphoma can also give you airspace disease, ill-defined consolidations, nodular opacities, etc. So it can be Hodgkin's or non-Hodgkin's lymphoma. So parenchymal lymphoma, this one has predominantly these mass-like opacities that have air bronchograms within them. So that when you see air bronchograms like that within these opacities, that's what makes you think about an infiltrative process, a process that's involving the air spaces. Okay? So these are alveolar infiltrates, can be from cells, mucinous adenocarcinoma, lymphoma, alveolar sarcoid. Interesting finding on this case. What do we call this? So this is crazy paving. How do you identify it as crazy paving? What makes it crazy paving? So you have ground glass opacity with septal thickening, with interlobular septal thickening, and also what? Intralobular septal thickening. There's also thickening inside the lobule. Also, it's geographic, meaning that there are areas of lung that are spared. So it's this patchy distribution of these consolidations, ground glass, interlobular, and intralobular septal thickening with a patchy distribution. What is the unusual finding in this case? Yeah, there's a thick-walled cavitary lesion. So how do we put that together? What do we think is going on? Well, if we have crazy paving, right, the disease the textbooks talk about with crazy paving is pulmonary alveolar proteinosis. But how do you get a cavitary lesion with that? Yeah, superinfection. So these patients are prone to superinfection, especially nocardia, aspergillosis, also another unusual organisms. But nocardia superinfection in a patient with pulmonary alveolar proteinosis, that can give you the cavitary lesion. Right? So pulmonary alveolar proteinosis impairs alveolar macrophage function. So these patients are prone to infection. So we're in the category now of proteins. So pulmonary alveolar proteinosis, this is caused by impaired clearance of surfactant or surfactant derivatives. There are causes of this, most of it is autoimmune from this type of antibody to granulocyte macrophage colony stimulating factor. So this antibody then causes dysfunction of these macrophages, which are supposed to clear these products of surfactant. They don't clear it, and so it builds up, and that gives you pulmonary alveolar proteinosis. There are secondary forms from toxic agents, massive exposure to silica can also do that. That's called silicoproteinosis, or you can also see it with infections and malignancies. And then very rarely genetic mutation in the surfactant itself or in the receptor genes for that stimulating factor. So these are usually in infants who develop alveolar proteinosis. Okay. Most cases will be here. These will be adults. This is kind of the acquired form of alveolar proteinosis is what we will usually see. So a large amount of proteinaceous material in the alveoli, susceptible to infections, consolidations on the chest radiograph. The clue is the patient is often not as symptomatic as the radiographic abnormalities would suggest. So the x-ray looks really bad, the patient doesn't look so bad. So that's the clue for pulmonary alveolar proteinosis there. Crazy paving, we've talked about, that is the finding associated with alveolar proteinosis. Just about all patients with alveolar proteinosis will have crazy paving, and it's this classic appearance of crazy paving that you see with alveolar proteinosis. Why is it called crazy paving? Garden floors, this is the pattern of stones, that's called a crazy paving pattern. So here's your interlobular septae, and so that's what we get with alveolar proteinosis and the crazy paving appearance. The treatment is pulmonary alveolar lavage. So these patients develop the buildup of the surfactant, they remove it with alveolar lavage. That is the treatment. Rare form of this is from massive exposure to silica. These patients can develop nodules, ground glass opacities. Again, this is a surfactant-like material that builds up there within the lungs as a reaction to the inhalation of silica. So these are usually sandblasters that can develop this acute silicoproteinosis from exposure to that. What are other causes of crazy paving? Now, alveolar proteinosis, that's extremely rare, right? So in most cases, if you see crazy paving, it is caused by something else. So there are other causes of crazy paving. It is not very specific, it's not specific for alveolar proteinosis. So in clinical practice, if you see it, it is probably something else, okay? Pulmonary edema is probably the most common thing. If you come across crazy paving, it's probably pulmonary edema. You can also see it with alveolar hemorrhage. You can also see it with ARDS. Viral pneumonias can also give you crazy paving. So there are many other things that can give you crazy paving besides alveolar proteinosis, although that is something that you need to consider, especially if you're taking a board exam and you see crazy paving, okay? Bronchoalveolar carcinoma, pneumocystis. This can give you crazy paving also, pneumocystis pneumonia. Lipoid pneumonias, rare case of sarcoid giving you crazy paving. So many other things that can give you crazy paving. So that is our discussion of alveolar consolidations, and especially if they're chronic, right? What things do you think about? If it's infection, TB, fungal infections, inflammatory eosinophilic pneumonia, if it's peripheral, lipoid pneumonia can do it. Cells, mucinous adenocarcinoma, lymphoma, alveolar sarcoid, pulmonary hemorrhage, although here it's usually recurrent, right? So you pull out an old chest radiograph, there are consolidations, patients comes back to the ER, there are consolidations, and it turns out to be hemorrhage. And then alveolar proteinosis, also PAP also can be recurrent. The patient shows up with different episodes of alveolar proteinosis. So when you look at the old films, you find that, wow, there's a track record of coming back with these consolidations. Okay. Any questions? All right.